If we think about an alternate disease of follicular lymphoma or low-grade lymphomas, we're seeing a similar evolution of treatment. In this disease, we traditionally use chemotherapy with Rituximab as the initial treatment. Most patients will receive bendamustine and Rituximab as initial treatment for that disease. Other patients might receive Rituximab CHOP for follicular lymphoma. Both are highly effective strategies. But now in the relapse setting, we have two targeted therapies available for these subjects. We have the PI3 kinase delta inhibitor, Idelalisib, which in heavily refractory patients with relapsed follicular lymphoma, the response rate is 55%, and the median progression-free survival is approximately 1 year, showing activity in patients who have stopped responding to chemotherapy and Rituximab. Furthermore, in that population of patients, we have the drug Lenalidomide, which when combined with Rituximab in patients who've previously had chemotherapy, the response rate is about 75%, and the median progression-free survival of those remissions lasting is an average of 2 years, again, without chemotherapy-based treatment. At this very meeting, some exciting data was presented called the Catalan trial. This was a study specifically in patients with what we call Rituximab refractory follicular lymphoma. These are patients with low-grade or indolent lymphomas who'd received chemotherapy with Rituximab. Most of these patients had received R-CHOP as their initial therapy and then subsequent therapies at relapse. They'd received a median of 2 prior lines of therapy, though some of them received many more prior lines of therapy. And at the point where they were considered Rituximab refractory, which means their disease grew while receiving Rituximab, or within 6 months of receiving Rituximab, those patients we know have a poorer outcome compared to other patients with follicular lymphoma. And the full 80% of patients in this study were also refractory to chemotherapy at that time. This clinical trial randomized patients to the drug bendamustine alone, or bendamustine plus the newer monoclonal antibody, Obinutuzumab. And what this randomized clinical trial showed is that if you add Obinutuzumab to bendamustine, specifically in patients who were Rituximab refractory, that you improve the complete remission rate for those patients, and you double the progression-free survival to approximately 30 months compared to 15 months by including the newer anti-CD20 monoclonal antibody, Obinutuzumab, in the refractory setting. Ongoing studies looking forward are incorporating other drugs, including additional PI3 kinase inhibitors like Duvelisib, incorporating an anti-BCL2 drug called venetoclax, as well as alternate monoclonal antibodies and what we call antibody-drug conjugates. Furthermore, a randomized trial looking in the upfront setting of follicular lymphoma today has accrued patients and compared them with standard bendamustine Rituximab to the immunomodulating drug Lenalidomide combined with Rituximab, a chemotherapy-based approach versus a non-chemotherapy-based approach. That clinical trial has completed an accrual, and if it's a positive study, we might shift our landscape to where we're no longer giving chemotherapy, even the upfront setting, for follicular lymphoma. So in both chronic lymphocytic leukemia and in low-grade non-Hodgkin lymphomas, novel targeted agents are clearly changing the way we treat both relapsed disease and, in the not too distant future, even people with previously untreated disease.